Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media, nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I'm a clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. And today, we're going to be talking about some issues dealing with motor control and imaging in particular. Today, I have the privilege of interviewing Dr. Ken Weber. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have left reviews on iTunes. iTunes helps others find out about chiropractic science. So if you like the show, please take a second and write a review. It will support chiropractors everywhere. And recently got a review from Dr. Katie Benson, and she says, a great resource. I always look forward to new episodes. This podcast breaks down research in an interesting and easily digestible form. It's my favorite way to stay up to date on chiropractic research. Thanks, Dr. Smith. Well, thank you, Dr. Katie Benson, for that review, and thank you for listening to the podcast. All right, on to the podcast. Well, let's get on to the interview with Dr. Ken Weber. Dr. Ken Weber is an instructor in the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University. He obtained his Doctor of Chiropractic from Palmer College of Chiropractic, Florida, in 2009, and then completed a PhD in neuroscience at Northwestern University in 2016, specializing in movement and rehabilitation science. Ken's research intersects clinical pain research and advanced imaging techniques with an emphasis on brain, spinal cord, and musculoskeletal imaging. His research aims to better understand the neural and musculoskeletal changes underlying clinical pain conditions, the mechanisms of treatments, and predictors for recovery. Ken is currently supported by a K23 mentored patient-oriented research career development award from the National Institute of Neurological Disorders and Stroke of the National Institutes of Health. His previous funding has included the National Center for Complementary and Integrative Health, the National Institute on Drug Abuse, and the NCMIC Foundation, Inc. I'd also like to point out that Ken was recently selected to be part of the Carl Fellows program, the Chiropractic Academy for Research Leadership program. Congrats, Ken, and thanks so much for coming on the Chiropractic Science podcast.
Thank you, Dean. It's a great opportunity to be here.
Yeah, so first, why don't you tell us how you got into chiropractic?
Okay. So I really enjoyed science and math, and from a young age, I envisioned myself working in a field related to science, biology, or medicine. My family was strong proponents of chiropractic. I grew up in a blue-collar family in a small farming town in the Midwest. Lots of working outdoors, gardening, manual labor. My grandparents on both sides of my family utilized chiropractic care for musculoskeletal issues, as well as my parents. My father suffers from chronic low back pain, which he manages with chiropractic. I grew up going with him and my mother to see the chiropractor. Chiropractic was just a part of my life. Our family chiropractor ran an office from her house. It was a small but busy walk-in practice with a simple setup. She ran the whole show from billings to treatments. The simplicity of it was very appealing. And I felt that chiropractic could provide a very nice work-life balance. Next, my older sister attended Palmer College of Chiropractic in Iowa. Her and my brother-in-law are both chiropractors practicing in Round Rock, Texas. She was an important role model of mine. I visited her several times in Davenport when I was in college. She was very passionate about chiropractic and drew me into the profession. I also had a desire to pursue something different than the conventional medical career path. So my experience with chiropractic, my sister, and desire to be different led me into the profession, and I decided early in my undergraduate career that I wanted to become a chiropractor. My path at that time diverged somewhat from my sister's. I enrolled in Palmer, Florida instead of Davenport. I really wanted to get out of the Midwest for a bit. Florida allowed me to get away from the winter, and soak up some sunshine.
That's great. And you mentioned that you wanted a different path. Yeah, all of us chiropractors, I guess, are a little bit different that way, just by our nature. So, how did you get into research from chiropractic school?
Yeah, so it's been a long path. But as I mentioned earlier, science and math really interested me and came natural. They didn't really seem like work. I went to a local state university, Saginaw Valley State University in Saginaw, Michigan, for my undergrad, where I studied biology and chemistry. The university had a strong affiliation with the Dow Chemical Company, which is headquartered in Midland, Michigan, only a half-hour drive from Saginaw. After my first semester in college, I was able to get a position as a lab technician in emulsion polymer research, where I worked in an analytical lab for paper coatings, carpet backing, and paint. While I was mainly supporting the scientists in research versus actually advancing science, it was my first experience working in a research team, and I loved the environment and the work, and I worked at Dow for the remainder of my undergraduate career. However, when I went into chiropractic school, my main goal was to focus on my clinical training and to come out and start my own practice. That was my plan. However, shortly into the program, I saw the many gaps in our clinical knowledge. Whether that's regarding the theory behind certain chiropractic techniques, or just our understanding of the causes of neck and back pain and the best way to manage a specific patient. Overall, I guess I had a large amount of skepticism, possibly too much, and I sort of became fascinated and or frustrated by this lack of knowledge. So I started to seek out more evidence-based approaches to spine care, which in my opinion were not often the focus of what we were being taught at the time. So I read Dr. Craig Levinson's Rehabilitation of the Spine, Dr. Craig Morris's Low Back Syndromes, Dr. Donald Murphy's Cervical Spine Syndromes, which were not required readings for my classes. I also had Dr. David Seaman as an instructor, and he introduced us to this the vertebral subluxation complex and Gatterman's book by the same name. And I guess I just found out that there's really just so much to be learned, and my passion and motivation kind of changed towards the research and thinking of pursuing a PhD following chiropractic college. At that time, I started to reach out to all of the chiropractor DC PhDs that I could find to get their advice on how to best pursue a research career. This included doctors Partep Kulsa, Jeffrey Bove, Michael Schneider. A major piece of advice I kept hearing was that I needed to get more research experience to be competitive for a PhD program. So I started to seek out as many research opportunities as I could during my remaining time at Palmer. I began working with Dr. Sean Herr, my past anatomy instructor, on a chiropractic education research project that aimed to assess the research culture and research activities of chiropractic students at Palmer. This was eventually published in the Journal of Chiropractic Education. I also started working with Dr. Don Dishman on a project using two neurophysiological techniques, H reflexes and F waves, to study sensory motor inhibition following lumbar spinal manipulation in healthy subjects. This project was later published in the Journal of Experimental Neuroscience. Then during my chiropractic preceptorship, I moved to Chicago and started to work part-time as a research assistant under Dr. James Stanier, who was the director of the Neuroplasticity Lab at the Rehabilitation Institute of Chicago, now the Shirley Ryan Ability Lab. Dr. Stanier is a DC PhD. He graduated from Sherman College in 1981. He practiced in New Zealand for 20 plus years and was also quite active in the profession. This included being past president of the New Zealand Chiropractors Association and being involved in the establishment of the New Zealand Chiropractic College and acting as the college's first principal. If that wasn't enough, Jim then went on later to complete a PhD in neurophysiology at the University of Auckland, focusing on stroke rehabilitation and motor system plasticity. And then he became the director of the neuroplasticity lab at the Rehab Institute of Chicago, where he worked on different neuromodulation techniques such as transcranial magnetic stimulation, transcranial direct current stimulation, as adjuvants for stroke rehabilitation. Jim is now currently an associate professor at the University of Auckland. So I worked for Jim for almost a year part-time while I practiced part-time in private practice. This experience really got me interested in neuroscience research career, and I began applying to neuroscience PhD programs. In 2010, I started my PhD in neuroscience at Northwestern University, working under the mentorship of Dr. Todd Parrish. Todd is an MR physicist and is the director of neuroimaging for Northwestern Center for Translational Imaging. My PhD research focused on spinal cord neuroimaging in humans with MRI, including spinal cord functional MRI. In 2016, I started a postdoctoral research fellowship in clinical pain research at Stanford University under Dr. Sean Mackey. Dr. Mackey is an anesthesiologist and pain medicine specialist with a PhD in electrical engineering, and he pioneered some of the early work using advanced brain imaging to better understand pain. So here at Stanford, I've been transitioning my work in spinal cord imaging into clinical pain research, and I'm finally circling back to neck and back pain research. In 2018, I was promoted to instructor, and I currently have the pleasure of collaborating on a bunch of exciting projects with a large multidisciplinary group of friends and researchers across the globe.
Oh, excellent. It's a lot of great background, and I'm definitely interested in hearing more about this collaboration. And you mentioned about circling back. So I'd like to circle back to your practice. Do you currently practice these days?
Yeah, so while I've maintained my license, I do not currently have a clinical role. Maybe that will change. However, I've sort of bet everything on this research career, and there's only so much time in a week. So any time that I devote to clinical practice will take away, from my research output. And as you know, the skill set is quite different. Initially, I planned to maintain at least a foot in the clinic while I pursued my research training. However, I have not been successful at that. I was not able to, really to find a practice for part-time work in the Chicago area, which was convenient and suited my style of practice. But then again, I may not have looked hard enough. The research was driving me. I did study with several physical therapists during my PhD who were able to work flex shifts in the hospital on a part-time basis as they had time during their PhD. Unfortunately, this option was not available to chiropractors. I feel as the profession, though, becomes more integrated within hospital settings, it'll only make it easier for chiropractors working towards their PhD to maintain a clinical role.
Yeah, that's cool. And I really hope to see more of that kind of thing happening within our profession. I think it's a natural consequence and will happen more and more as we progress. So, Ken, why did you choose neuroscience?
So when I started looking at PhD programs, I was interested mainly in getting research experience. And I think I could have been happy in many different fields. I chose neuroscience because I thought it encompasses much of what back and neck pain are, and I could try to really get at the cause of these conditions. For example, I received training in pain neurophysiology, sensory motor integration, motor control, neurophysiological techniques, and statistics. Another nice thing was that Northwestern's program was also affiliated with the Rehabilitation Institute of Chicago, as well as the strong physical therapy and human movement sciences program at Northwestern. So being in neuroscience program, I was still able to specialize in movement and rehabilitation sciences. I also just personally enjoy the technical aspects of neuroscience, working to quantify neural responses and understand the nervous system and its role in back and neck pain are pretty fun.
Absolutely. And you're speaking my language there with sensory motor integration and motor control. Love it. So I also understand that you're involved in Parker's Clinical Neuroscience Master's Program. Can you tell us a little bit about that?
Yeah, since last summer, I've been involved in the Emerging Themes in Clinical Neuroscience course, which is part of Parker's online Clinical Neuroscience Master's Program. I was asked by my past mentor, Dr. Don Dishman, the program director, to help out. The course I teach covers neuroimaging and contemporary mechanisms of spinal manipulation and pain quantification, as well as pain neuroscience education. And we touch a little bit on big data and machine learning, sort of, maybe where the field and tools we'll be using, 10 years from now. The fun part is, that the students are required to read about 3 publications a week on these topics, which gets the students used to reading and extracting information from the scientific literature, which is a skill that takes a lot of practice. And for one of the articles each week, I make the students submit a written critique, kind of like they were reviewing that article for a journal, and they need to determine whether it should be accepted or rejected for publication. And I think this critical appraisal part of the course is the most important component and skill they learn. And for me, it's fun to see how much they improve over the course, and it's great to get their input on what they think about these articles and the findings and interpretation. It's been a really great experience.
Oh, that's cool. Yeah, I think I learned a new word, Ken, chronification. I'm going to use that now. Cool.
Yeah, it might not be in the dictionary. I'm not sure.
No, but I like it anyway. So thanks for that. Ken, you've been published in top journals such as Spine, Archives of Physical Medicine and Rehab, Arthritis and Rheumatology, Journal of Orthopedic and Sports PT, Physical Therapy, and many others. We're going to try to get through some of your expertise today. And to do so, I think if we could break down some of your research into various topics, that would be helpful. So how about we start with how we can understand pain and sensory motor function using advanced MRI techniques and measures. So can you tell us, first of all, what a typical MRI is good for?
So MRI, magnetic resonance imaging, which I'm sure most of the listeners are familiar with, uses strong magnetic fields and radio frequency pulses to generate images from hydrogen atoms. You use a radio frequency pulse to excite the atoms, which generates the MR signal. You spatially encode this signal, and then you collect that signal to create an image. The main advantages of MRI is that you can create images of different orientations and size. It's not just single 2D images, but you can also generate these 3-dimensional images. And you can create images with different contrasts without using any ionizing radiation. That part of not using any ionizing radiation is really great for clinical neuroscience in that we can repeat imaging in humans without worrying about any harm to the individual. So since starting my PhD, I've probably received an MRI probably every other week for my own research, which adds up, to a couple hundred times where I've been in the scanner. But those repeated measures, there's no harm necessarily that's going to come from that.
Huh. No, that's interesting. Getting all of those scans. I just find it tough to be laying in the scanner. I've only had a couple myself, but wow. Just curious, have you noted any significant changes or interesting things after you've received all these MRIs over the years, Ken?
Yeah, well, I haven't gone back and, looked at the images over time and like what we've collected. Usually it's that we're just piloting a sequence for a study and we're not actually collecting that data as part of an ongoing study. Usually I just look at it and then kind of just file it away. But it'd be interesting to do is, go back and look through it all. I do know that I have a disc herniation at C5, C6, which continues to persist, but fortunately, I don't have any symptoms.
Well, I'm happy to hear that. So what's the difference then between T1 and T2 weighted images? I hear these, all the time, and periodically I have to look it up just because I forget what they are. So maybe you can tell us about that.
Yeah, I think it takes a while to get your head wrapped around all these different terms. But I mentioned that MRI provides images with different contrasts, and contrast is just a difference in intensity in an image. So for an example, on a typical T2 weighted image, the CSF is bright while the bone is dark. So a T2 weighted image provides high contrast between the CSF and the bone. The reason for the different contrast is that the bone and CSF have different magnetic properties, which differentially influence the signals received from those tissues and the resulting contrast in the image. So depending on how you time the excitation of the tissue and the collection of the MR signal, you can create images with different contrasts. So T1 and T2 refer to the time that it takes for the MR signal to recover in the longitudinal direction, that's T1, or decay in the transverse plane, that's T2. So T1 weighted and T2 weighted images are designed to create images with maximum contrast based on the T1 or T2 of the tissues of interest. MRI's main benefit, clinically, is that it provides excellent soft tissue contrast and can provide contrast, between bone and muscle, as well as CSF, gray matter, and white matter, without the need of any sort of endogenous contrast agents. This is particularly beneficial when we try to visualize spinal anatomy, where MRI can provide information on the disc and bone pathology in relationship to spinal nerve roots and the spinal cord itself. And when all this gets combined, the imaging with other pieces of evidence, such as the history, exam findings, and other testing, it can help guide in the clinical decision-making for a patient. In addition to tissues having different magnetic properties, physiological processes can also affect the MR signal. And you can tune your sequence to capture these signals, these differences in the signal, and you can create an image with a contrast based on that physiological process.
Yeah, I want to dive a little bit deeper into this and talk about advanced MRI, if you could, and what your research is using this advanced MRI for.
Yeah, so I would summarize my research as having three aims. The first is to develop imaging modalities and techniques that are more sensitive and specific to the pathology, providing more diagnostic, prognostic, and predictive information. The second, is to provide more quantitative information to the clinician. So you could imagine in the future, a radiologist maybe spending less time focusing on identifying the area of pathology, but maybe they act more like an actuary, where they now have this abundance of metrics that we extracted from the series of images, and then they can use this quantitative information to base their clinical decision making. This relies on using machine learning and statistical techniques to automate the extraction of these metrics from the images. And then third, my third aim is to use these measures to better understand the nervous system and how it functions, the neurophysiology of pain, how treatments work, and why certain treatments work for some patients but not for others. Hopefully, this could be used, information could be used to treatment stratify patients, to the best treatment, and improve current treatments, and then maybe even develop new treatment approaches.
Yeah, for sure. I mean, stratifying people and subclassifying or classifying folks into different categories seems to be all the rage these days. And, there's some good research on some of that subclassification, but a whole lot needs to be done for it. And I think clinicians out there really could benefit from these sorts of techniques to be able to identify people quicker or be able to categorize, who might respond to our care most appropriately. That's great. So can you talk about advanced MRI techniques that you use in your research and what they're good for? Like, for example, are we able to look at white matter tracts, and how might this be useful for us?
Yeah, so my research focuses largely on advanced neuroimaging techniques for the brain and spinal cord. I dabble in some musculoskeletal spine imaging as well. There are three main techniques that I use in my research. These are volumetric structural imaging, functional MRI, and diffusion MRI. So we'll start with volumetric structural imaging. So for this, we typically acquire a full brain T1 weighted 3D image of really pretty high resolution. So we're looking at like 1 millimeter cube resolution or less. And these images can provide excellent white matter to gray matter contrast, so you can see the borders between these. And then using some advanced image analysis tools, we can actually extract gray matter measures from these images. And this includes measures of cortical thickness and gray matter density, as well as the volumes of subcortical and brainstem nuclei. So for example, we can see how cortical and subcortical gray matter differs between controls and chronic pain conditions or changes with the course of treatment.
Yeah, that's pretty cool. So how long might it take to see the effect of an intervention using this type of imaging? Can we see it right away, or does it take weeks or months?
Yeah, so for changes in gray matter, the time scale is usually months. There are motor learning studies that have showed changes in a shorter time scale of 1 to 2 weeks of learning a new motor task. The field's still new and developing, and there's only really a handful of longitudinal studies that are investigating pre and post treatment changes in the brain for musculoskeletal conditions. There is a 2018 pain medicine study which identified changes in gray matter changes at around 6 months post total knee replacement.
Fascinating. Yeah, and in the field that I teach in, exercise, it seems that there's significant effect over time. Of course, dealing with an increase in gray matter with activity. So that's interesting. I look forward to some longitudinal studies to come out within our field, perhaps to look at what, if any, changes might occur. Pretty cool. So I've read several studies that use functional MRI and show interesting pictures of brain activation. How does functional MRI work?
Functional MRI is a technique that provides information on neural activity and can be used to see regions of brain activation during, let's say, a motor task or sensory stimulation, for example. So you can use functional MRI to look at how information is processed or shared between brain regions at more of a network level also. So looking at activation during a task or trying to get information about processing between brain regions. So for example, we can see how maybe brain regions are talking to each other. As mentioned earlier, with MRI, it may be possible it's maybe possible to create an image that's sensitive to a physiological process, if that physiological process can alter the magnetic signal. Functional MRI relies on the blood oxygenation level dependent contrast or bold signal. Oxygenated hemoglobin and deoxygenated hemoglobin have different magnetic properties, which alter the magnetic signal. So with neural activity, your vascular system will actually send more oxygenated blood to the active brain regions to support that region's metabolism. So the increase in a local oxygenated hemoglobin concentration will lead to an increase in the MR signal in that region and a brighter pixel in the MR image. In functional MRI, we collect multiple brain images over a course of an experiment, which lets us see how these brain oxygen levels change over time. And then these images can be analyzed and to map neural activity across the brain.
Yeah, I'm thinking about the chiropractic literature, and I can think of one study that I believe used fMRI in men. It was a small scale study, and they try to show a pre-post change using fMRI. I haven't seen any repeats or replications of that. And that was, probably 5 or 6 years ago. I believe they use activator as the adjusting technique for that. But so also curious, how does fMRI compare to something like EEG?
It's EEG, so that's electroencephalography. Is another neuroimaging technique that can measure neural activity. With EEG, you're picking up voltage changes from the brain's cortex due to neural activity. The one major difference is that with fMRI, we can get a higher spatial resolution than EEG, and we can look deeper into the brain, so at deeper brain structures like brainstem and areas that are kind of farther away from the cortex. One of the disadvantages of fMRI is that because it's based on blood flow changes, the timescale is much slower than EEG. So with fMRI, you're kind of looking at activity in the second to half second range, where with fMRI, sorry about that. With fMRI, you're looking at the activity within the second to half a second range, which EEG is much faster. fMRI is also, more expensive than EEG, which is also something to consider when you are designing your experiment.
Yeah, I know. I went to a place in Florida for a conference, and they used fMRI, and it seemed like that scanner was going pretty much 24 hours a day. I couldn't believe it. That was like 20 years ago, and they were just cranking out the studies, which actually brings me to my next point. Can these things be used clinically? And if so, how are they used clinically?
Yeah, so the main use of functional MRI clinically is in preoperative planning. So for example, if you're going to undergo brain surgery, you may undergo a functional MRI session that could be used to identify the brain regions, let's say, that are responsible for speech. So then the surgeon can use this information to kind of stay clear of those areas during the surgery to prevent speech deficits. Gotcha.
Well, how about the next topic I think you were going to talk about was diffusion MRI. Maybe you can tell us a bit about that one.
Yeah, so diffusion MRI, we can use this to look at white matter in the brain. Diffusion is the random movement of molecules. If you drop, some dye into a glass of water, eventually that dye will diffuse throughout the water. Diffusion of water is also occurring in the brain and your tissues. However, the cellular structures in the brain can limit the direction of diffusion. So for example, in the gray matter where the cell bodies are, which are round-like, the diffusion is primarily isotropic, which is diffusing equally in all directions. But in the white matter, where you have the axons that go between cells, these axons make the water diffusion more limited to the axis of that axon, so that single direction. So in diffusion MRI, we can collect a series of images that are sensitive or have contrast to the different directions of diffusion. And the series of images can be mathematically combined to provide information on the magnitude and direction of diffusion in white matter tracts, and provide information on the quality of white matter tracts, such as myelination, the size of the white matter tracts, and the strength of structural connections between brain regions.
Now we're starting to get more into my language here, motor things. So how can we use this clinically, or do we use it clinically yet?
Yeah, so because diffusion-weighted imaging is so sensitive to water movement, Areas of edema and cell swelling can be identified quite well with diffusion imaging. So the main clinical use, commonly used, is if a stroke is suspected, diffusion imaging is usually included. It's very sensitive to ischemic changes within minutes of a stroke.
Yeah, this is interesting. So are there any contrast agents needed for any of these MRI techniques that we've just talked about?
Yeah, so contrast agents, they have a role in MRI, but all of the imaging sequences that I discussed and do not have to use any contrast. So it's pretty amazing that you're able to get this much information about the anatomy and even physiology without having to use any contrast agents. And I think that's pretty amazing. That's why I find MRI to be so fascinating. If any physiological or physical process could affect the magnetization, you can may be able to create an image that's sensitive to that. Yeah, so I guess just together you can take these three techniques combined, kind of provide information on the gray matter, the white matter connections between these brain regions, and just the overall functional network and neural processing. Hopefully that's kind of clear, but you can kind of see how all of these different measures can come together and kind of complement each other and really give us a pretty impressive view of the nervous system.
Yeah, definitely. And, my brain, the practitioner in me says, well, I haven't seen other practitioners order these things, maybe just because I'm not dealing with stroke patients for the most part, and I'm not in the hospital. So is it common would a chiropractor order these things, or are they primarily just for research now? Or, should we be looking forward to these things in the future, I guess?
Yeah, a great question. So the development of these advanced brain imaging techniques, has somewhat outpaced the clinical research, especially musculoskeletal care. Structural and diffusion imaging have important roles in diagnosing brain pathology, and then functional MRI has its role in pre-surgical planning. But for back and neck pain and other pain conditions, these tools are primarily research tools right now, but they have had an impact on clinical practice. While we're still figuring out the clinical translation for these tools, these neuroimaging tools have increased, our understanding of pain processing, and this knowledge, has affected clinical practice. It's shown us that processing of nociceptive and pain information in the brain is quite complicated. For example, the pain experience, is not encoded by any single brain region, but it's distributed across the brain. And somehow across this network of brain regions, there's the different dimensions of pain, the pain experience kind of come together and create the individual's own perception of pain. And I think just showing this complexity of pain processing and the pain experience kind of has had a major impact, with how we communicate with patients. And, we try to kind of, reduce through education, reduce the focus on the pain itself, get patients not to equate pain with injury, and to be more engaged in activity. And those kind of recommendations that I think the neuroimaging literature kind of has supported those efforts.
Yeah, definitely. Those have translated, I think, pretty well into practice. At least many of the practitioners that I speak with seem to be getting that message, I think, loud and clear. So this is great, and hopefully we'll just see more and more of this translation come from these advanced studies. So Ken, thanks for going through and describing these different types of MRI techniques. Much of your research has been in spinal cord fMRI. So what's different and unique about the spinal cord?
Yeah, so my work has largely focused on optimizing techniques to improve our ability to use these same measures I discussed for the brain, but for the spinal cord. Specifically, my work for my PhD focused on measuring sensory motor function with spinal cord functional MRI. There are some, I guess, unique challenges that make imaging the spinal cord quite difficult. First, it's the size. It's small, around 1 centimeter in diameter. And the gray matter and white matter are in the millimeter range. Therefore, we need to use special techniques that can provide higher resolution for imaging in the cord. As you go to smaller resolution with MRI, you're reducing your signal that you're collecting. So you've kind of got a trade-off there. And then the next thing is that the spinal cord is a very noisy structure. You have these CSF pulsations, which can influence the signal intensity. The spinal cord itself moves during the cardiac cycle, during the respiratory cycle. Then you also have noise, let's say in the cervical spine, for example, which is mainly where we're imaging. For my research, you have the neck vasculature. There's motion from swallowing. It's overall just a pretty terrible region for MRI with all of these sources of noise that can reduce the signal quality and cause artifacts in the images. And then the last major hurdle is that we haven't had the tools available to analyze the spinal cord images. Most neuroimaging analysis packages that exist have been designed for the brain. So kind of just to get around these challenges, we try to use some special imaging sequences that allow us to image faster and at higher resolution. And recently, tools that are specific for spinal cord imaging have become available. And just in the last couple of years, the techniques have advanced quite a bit. And I expect that in the next decade, there's going to be a major increase just in the spinal cord imaging field overall. And so using a combination of these different imaging and analysis approaches, we can now capture gray matter volumes in the cord, whether that's the dorsal horn or ventral horn. We can measure diffusion metrics along specific white matter tracts. So you could look at corticospinal tract in the cord if you wanted. And then we can also obtain measures of neural activity in the spinal cord with functional MRI. There's definitely still plenty of room in these methods, but we're kind of at the stage now where we have the tools and the field is wide open for study. So it's quite amazing. I get excited about it just to see the progress that's been made already in the field over just my short research career.
Yeah, I mean, everything is just so fascinating. I wouldn't normally think about capturing the signal and having to worry about, respiratory motion artifacts that occurs on a cervical spine, for instance. So that's kind of a wake-up call, and I'm sure, as you said, it's somewhat difficult or challenging to deal with some of these artifacts, but the precision of the images and being able to get to a single track, that sounds just mind-blowing. I look forward to lots of studies coming out that, maybe we can use this clinically. Well, hopefully we can. I guess that's the idea of all of this research and trying to translate it. So I'm sure it will be coming, and hopefully soon. So what type of conditions or case presentations would these scans be useful for in practice? And have you ever heard of a chiropractor ordering these types of MRIs?
Yes, again, the field is pretty new. There is some evidence that these measures are sensitive to injury and pathology. To date, spinal cord MRI changes specifically functional MRI changes have been seen in fibromyalgia patients, cervical spondylotic myelopathy, multiple sclerosis, spinal cord injury. We've seen structural changes in ALS, spinal cord injury. Right now, I'm currently working on a longitudinal study using these spinal cord techniques as well as brain imaging to identify markers of pain and sensory motor function in cervical radiculopathy patients. Right now, it's kind of similar to the brain where we're at. And I think these techniques will likely first show clinical utility in the pre-surgical area. In that I collaborate with Dr. Zachary Smith. He's a neurosurgeon, previously at Northwestern, but now at the University of Oklahoma. And he treats many patients with cervical spondylotic myelopathy. And it's a multi-level degenerative condition affecting the spinal cord and can lead to sensory motor issues in the upper and lower extremities due to chronic compression of the cord. One of the challenges with this disease is that it typically presents in older patients who may also have comorbidities. And if you're going to consider surgery on these individuals, you only want to do it kind of on those patients that you know that are going to improve. So I think probably the first area where these techniques could be able to be used is to kind of predict who may recover. So perhaps these measures could provide a measure of nervous system health or the capacity of the nervous system to recover following surgery. If so, you could prevent patients that are likely to have poor outcomes from undergoing surgery in the first place.
Yeah, well, that would be fantastic for sure. Well, thanks for going through that, Ken. I do want to talk about a couple of your papers on spinal cord. And first, if you could tell me about a 2016 paper, and this was called Lateralization of Cervical Spinal Cord Activity during an Isometric Upper Extremity Motor Task with Functional Magnetic Resonance Imaging.
Yeah. So this was the first author, my first author paper for my PhD. So it's one of my favorites. The study focused on using functional MRI, which again is technically challenging, to localize activity in the spinal cord and assess the reliability of the location of that activity. So around when I started my PhD, there had been probably about 100 papers published in spinal cord fMRI. But in my opinion, the signals from those papers, did not appear to be necessarily very localized, and the reliability of spinal cord fMRI kind of had never been reported. So for this study, what we did, we used some new fMRI sequences and analysis techniques that hadn't been used. And we had participants perform a simple left and right-sided isometric wrist flexion task. And we did this over several runs. So I think we collected about 30 minutes, I think, of data per subject. So we had a lot of data also. And the results showed that activity was localized to the corresponding left or right hemichord. So if you move your right hand, we saw activity in the right spinal cord. If you moved your left hand, we saw activity in the left spinal cord. And this is expected based on the corticospinal tract and where your motor neurons are located in the spinal cord. And we weren't just able to see this laterality across all the subjects, but we were actually able to start to see it at the individual level. So let's say if I scanned you, we'd be able to, and you moved your right hand, we'd be able to see that right-sided activity. And if you moved your left hand, we'd be able to see the left-sided activity just in an individual, which is quite remarkable just given the amount of noise and difficulty with some of these techniques. And then we also looked at reliability, and across shorter chunks of time, so 5 to 6 minutes, we were also able to see that laterality at shorter durations of imaging. This kind of just seems pretty simple, but in comparison, laterality of brain activity during a similar motor task was reported in the early 90s. So, now it's been, that's more than 20 years ago. So we're now just finally getting to a similar level of detail in the spinal cord. And since then, we've also investigated activity with thermal stimulation. We've looked at recently tactile stimulation at different dermatomes. This study was just recently published in Neuroimage this May.
Cool. So, Again, the chiropractor in me is thinking, okay, we, adjust at a certain level, and what could we see on these images? That would be cool. So another paper that caught my attention was lateral corticospinal tract damage correlates with motor output in incomplete spinal cord injury. And this was published in Archives of Physical Medicine and Rehab. Perhaps you could tell us about that one.
Yeah, this work was done in collaboration with Dr. Andrew Smith. Andrew is a physical therapist and neuroscientist at the University of Colorado, Denver. Andrew's research and clinical interests are in incomplete spinal cord injury and rehabilitation. One issue in spinal cord injury is the lack of tools kind of to predict who may recover sensory motor function after an injury, or which treatment might be best for which specific patient. So in this study, we used high-resolution submillimeter structural 3D T2-weighted imaging to investigate the relationship between the lesion area and specific white matter tracts. So we're able to have high enough resolution that we're able to identify the lesion, its full 3D extent, and then see kind of where it's located with respect to other tracts. And so we found that the amount of corticospinal tract damage was correlated with lower extremity motor function in an ipsilateral manner. So if you had more damage to your right corticospinal tract, you're likely to have more deficits in your right lower extremity, and vice versa for the left side. Again, this seems pretty obvious. That kind of maybe should happen based off of our understanding of neuroanatomy, but we haven't had the tools to kind of do this sophisticated of an analysis before in humans. So there's just a lot of low-hanging fruit that's there, to explore, now that we have these tools.
Yeah, and like you said, I mean, if we haven't had these tools to visualize it, I mean, there's different, tools like EEG and things that have been around for some period of time, but actually being able to see it, I mean, how cool is that, right? Yeah. That's awesome. So another topic I want to discuss is machine learning, and wow, what a buzzword these days. And it sounds like you're using machine learning to identify patterns in MRI, and are we able to predict pain and what sensory motor function is like with this?
Yeah. So I think machine learning is it's a hot topic and a buzzword. It's not necessarily new. It's been used for years in many of our computer and phone applications. Machine learning algorithms are what drive your Amazon purchase recommendation. It's your Facebook news feed, your suggested movies on Netflix, etc. In recent years, there's been some dramatic improvements in the fields of visual and speech recognition, which has received quite a lot of attention. How does machine learning, differ from standard statistics? I feel that machine learning is often discussed in sort of a black box, overly technical manner. Hopefully, I'll try here just to demystify it some. So you have machine learning and then classical statistics, and between them, there's quite a lot of overlap, and they're actually quite similar. With classical statistics, we're using it to identify patterns in data, with a main focus, I think, on inferring relationships between variables, and then making a determination on how likely these relationships occur relative to chance. And if that effect is or relationship is large enough, then we believe it's true. Machine learning is similar in that you use similar statistical models. You can use linear regression, for example, to identify patterns in the data. But you kind of take it one step further in that you use that model to make a prediction about an unseen independent data set to further validate that model, but then you can also see how well that model performs on data it hasn't seen. And if it's sufficiently accurate, you can then use that model for the intended application. So the focus in machine learning versus classical statistics is to be more on the use of the model to predict rather than the inference of the features driving the prediction. So why those features maybe necessarily are driving the prediction. For example, Amazon may not care exactly why their model suggests a product for you as long as you purchase it, right? Therefore, kind of with machine learning, you may be okay including more variables in these models, maybe tens or to thousands of variables, because you're not so much concerned about interpreting the model, but more just about the accuracy of the prediction. So tends to be a less of an emphasis on inference, maybe, and more of a on using the model to make predictions. That's sort of what I think makes machine learning, I guess, different than classical statistics. One caveat, though, is in my research in neuroimaging, we not only want to use machine learning to identify predictive patterns, but we also want to know what brain regions are driving that prediction. So, for example, if a specific set of brain regions predicted a response to treatment, we may want to, or may think that those brain regions are somehow have a role in that condition, whether that's back pain and or are somehow involved in the treatment mechanisms, let's say. So in that way, we are not just concerned about making that prediction, but we also have ways that we can see what's actually driving that prediction and interpret these models, which sometimes can be quite large.
Okay. Yeah, I think I get the distinction now. Thanks for going through that. So you've used some of these techniques in your recent publication and scientific reports, and this is, I found interesting, a bit more musculoskeletal in nature, and this was deep learning convolutional neural networks for the automatic quantification of muscle fat infiltration following whiplash. So perhaps you could tell us about this study and how you use machine learning within that study.
Yeah, so this paper is from a project by Dr. James Elliott, who is at the University of Sydney, and also Dr. Andrew Smith again, in addition to collaborators at Stanford and Northwestern. A major part of Jim's research is understanding the factors, biological, psychological, and social that predispose one to develop a persisting chronic whiplash-associated disorder versus those that recover following a motor vehicle collision. The severity of a motor collision, from what I understand, is actually not that strong of a risk factor for predicting persisting whiplash symptoms. So in this study, we're using an MRI technique that allows us to create images with contrast between water and fat, and it's called the Dixon technique. And so we can use these images to identify the fat content of muscles. And through quite a bit of Jim's work and others, it's been demonstrated over many studies that consistently within individuals with chronic musculoskeletal condition, they tend to have higher levels of fat content in the muscles associated with that condition. So for whiplash, for example, those that develop chronic whiplash tend to have higher levels of muscle fat in the deep cervical extensor muscles, and which tends to be associated with their level of neck-related disability. It still remains kind of unclear and needs to be understood better by whether that higher fat content develops following the injury or whether higher fat content at the time of injury makes you at greater risk for developing chronic whiplash-associated disorder. Perhaps the higher fat indicates poor muscle function and maybe decreased ability to dissipate the flexion extension forces experienced during the whiplash injury. So to better understand the relationship between this, the muscle fat and persisting whiplash symptoms, Jim completed a large study that longitudinally tracked 100 individuals with acute neck pain following a motor vehicle collision over the course of a year and collected these imaging at 4 different time points. So a major barrier in this research is calculating the fat content of the muscles, and it requires a researcher with some expertise to go in and manually identify or segment muscles in the images. And this can be an extremely long process and take hours per data set. And if you think clinically, no radiologist is ever going to routinely go in and circle muscles, to get you fat measurements in the neck for clinical care. It's way too inefficient. So I had recently heard of these major advancements at Stanford and other universities in computer vision technology. The technology is convolutional neural networks, which is a fairly new statistical model that works on images and was showing human level performance in tasks such as tumor identification and organ segmentation. And when I was reading through these, I immediately thought of Jim's research and thought we should give it a try and maybe save a graduate student hundreds of hours of work.
That would always be nice.
Yeah, and it's not fun work. It's really boring. It you can get through a few, catch up on your Netflix, I guess, but it's mind numbing, and manual too, because you've got to draw these all out. It's tough work.
Oh.
So in this study, we had 3 individuals segment a data set. We trained this model on a portion of data set, and then we tested it on a held out portion. And to our surprise, the model performed very well. So, now instead of spending an hour or more segmenting the muscles from a data set, the model could accurately, segment the muscles in seconds. So, we've now expanded this project to a 14 muscle model, and identifying 14 muscles in 400 data sets. If we think about Jim's amount of data he has available, is like beyond most labs' capabilities. And to do that research, we need a way to automate it. So this more complex model, we're just starting to look at the findings, but they're looking very promising. And hopefully this automated 14 muscle segmentation project will be out later this year in print. And we plan to make the code and model available so anyone can use it. This project is kind of getting at my goal of automating quantitative measurements in MRI. Based on our current findings and how quickly the field is moving, I feel that within 10 years, you could start to see the automated extraction of these imaging metrics and then their inclusion in imaging reports. But of course, the impact that this will have on clinical practice and clinical outcomes, still remains to be determined.
Yeah, for sure. And, as you're going through that, I couldn't help but think about my own PhD, and I discovered macros in Excel and that they could save me hours upon hours of number crunching. And, I'm not a computer programmer type. So I rely on people such as yourself to figure these kind of things out or learn about macros or something like that. So this is fascinating.
Yeah, it's one thing I didn't when looking into starting PhDs. I didn't think I'd be doing a lot of computer coding, but I do it every day, and I really enjoy it. So
well, that's cool. And
interesting skill sets.
I absolutely, and I'd love to know how to do that. I'm jealous. Maybe I just need to start going to some courses and learn how that works. That would be good. So, Ken, let's take this machine learning and again try to get it to our clinical interventions, perhaps such as chiropractic adjustments. Is there any use at this point for how that might help?
Yeah, so great question, Dean. We have 3 main uses for these MRI techniques. One is that they could provide mechanistic information. That is, how is pain encoded in the brain? How does chronic pain develop? What are the mechanisms of a specific treatment? They can provide diagnostic information. What condition or combination of conditions is driving the clinical presentation in this particular patient? Maybe determine, let's say, the most pathological level, in multi-level cervical spine degenerative disease. Maybe they can provide prognostic and predictive information. Will this patient develop chronic pain? Will this treatment work for this patient? These are kind of the ways that we're trying to use MRI and machine learning to answer these questions. And if we can start to answer these questions, we'll probably uncover brain and spinal cord regions that we can uncover the ones that provide mechanistic and diagnostic and prognostic information. And these may also be helping us identify new treatment targets. So then we could use these, we'll target these regions with neuromodulation techniques such as transcranial magnetic stimulation or transcranial direct current stimulation, maybe optimize physical, psychological, procedural, or pharmaceutical interventions to target these specific regions and increase the effectiveness of current treatments. So we're working on it. Hopefully we'll be there in 10 years with some, straightforward examples of applications. But the field is really trying to, is trying to take it the next step and be able to translate these as clinical tools.
Yeah, I got it. And so again, we'll have to wait a little bit, but it's just, just thinking about all the possibilities. I want to do it now, Ken. I don't want to wait. Now, you've had a recent publication in Neuroimage Clinical, and this was evidenced for decreased neurologic pain signature activation following thoracic spinal manipulation in healthy volunteers and participants with neck pain. So could you tell us about that clinical study?
Yeah, so, when starting my PhD and neuroimaging training in 2010, I really had the goal to study manual therapy research, but that's not the path that ended up happening. It's kind of the way a PhD works, I guess. But this paper, means I'm finally getting back into it. It just took me 10 years. As I mentioned, I feel one of the greatest impacts that advanced brain imaging has had on clinical practice is by understanding of how the brain processes pain. And the field that, is really now working, the neuroimaging field is working on how to use these imaging tools clinically. This study used a machine learning model called the Neurologic Pain Signature, which was developed by Tor Wager, who was at Dartmouth. The original paper was published in 2013 in the New England Journal of Medicine. It's a great read and a really well-designed series of studies. The model was trained to predict pain from functional MRI data in healthy controls who experienced different intensities of painful thermal stimulation. It was shown to predict pain intensity in another set of participants. It appears not to predict social pain, and the brain model prediction was also shown to decrease with opioid administration. Now it's been further validated in several studies. So in theory, in practice, the idea is that you could take an fMRI, brain activation image from a painful stimulus. You could apply the model to it, and you get a score that is related to the pain intensity experienced by that individual. So Dr. Cheryl Sparks is a PhD-trained physical therapist who was at Bradley University and OSF Healthcare in Peoria, Illinois. She's now at South College. Cheryl, and you may remember these studies, had previously conducted 2 fMRI studies using fMRI to study mechanisms of thoracic manipulation. One study was a non-controlled pilot study in healthy controls, published in JOSPT in 2013. The other study was a randomized controlled trial in neck pain patients, published in JMPT in 2017. And in these studies, painful mechanical stimuli were applied to the cuticle during functional imaging. Thoracic manipulation was performed, and then the imaging was repeated.
So what kind of adjustment was used?
Yeah, it was an upper thoracic manipulation, performed supine, kind of like an anterior to posterior setup. The nice thing was that the manipulation was performed on the scanner bed and didn't require moving the participants out of the head coil, which receives the MR signal. So it was quite a nice setup for just a study design. And I guess I knew about Cheryl's studies, and so I had the idea to take another look at the data set. And I was starting to work on machine learning training, and I was curious if we could apply the neurologic pain signature to the brain activation images pre and post manipulation, and see how or if this neurologic pain signature tracked the pain ratings. And I feel like this is a really nice example of just an interdisciplinary collaboration and kind of just taking another look of a pre-existing data set. But we had 3 goals for the study. One was just to introduce brain-based models of pain for spinal pain and manual therapy research, just kind of, let the field know that these tools exist, and maybe we can get some ideas on how to use them. Second was to better characterize the central mechanisms of spinal manipulation. Does spinal manipulation seem to affect this pain network. And then finally, just to further validate these brain-based models as potential clinical biomarkers of pain.
So that sounds like an interesting interprofessional collaborative project, and another nice way to look at the data set. So what'd you find in this study?
Yeah, so we saw that in both studies, the neurologic pain signature was reduced following spinal manipulation. The pain signature activation strongly tracked perceived pain in the first, albeit non-controlled study. But the relationship between the neurological pain signature activation and pain measures was less clear in the second study of neck pain patients. There's several limitations to the study, and there's certainly much room for improvement, but I think the findings are promising. It does provide some evidence that spinal manipulation may alter pain-related activity within brain regions specific to the processing of physical pain. It also introduces and further validates the use of these kind of measures to study manual therapies, which I think is pretty cool.
Yeah, so just cool. And I want to ask a question about the particular regions of the brain. Now, before you mentioned that the pain is sort of distributed, if I remember correctly, across the various regions of the brain. Was there a particular region that was associated with this thoracic manipulation that you found?
Yeah, so it's a little hard to say exactly what regions were responsible, but there is an overall decreased network activation where it's a distributed network. So there's somatosensory areas involved. There is cingulate cortex, insular areas, medial prefrontal cortex that are combined within this. But as a whole, it seems to decrease. There were some individual differences in pain regions. Was those findings may have just been due to a small sample size, and it's not necessarily clear what any of those mean. So I think further larger studies are necessary to kind of really tease apart what areas could be, leading to that reduce in the pain experience.
Cool. So, Ken, you were recently awarded a new grant from NIH. What types of projects are you currently working on, and what are you thinking in the next, few years?
Yeah, so I was fortunate, to recently awarded a 5-year career development award from the National Institute of Neurological Disorders and Stroke. Because it's a career development award, the award has a training component and a research component. The training component has focused on machine learning and advanced brain imaging and really learning a lot of the techniques that I described. And then for the research, we're currently enrolling patients with cervical radiculopathy and performing advanced structural, diffusion, and functional brain and spinal cord MRI in these individuals. And the patients we're going to track over a course of the year, and then we're going to repeat the imaging. We're also collecting imaging in age and sex-matched controls as well. So the goal is to use machine learning models to develop biomarkers of pain severity and sensory motor function, and see how these measures, track these measures over the course of cervical radiculopathy. It should be pretty exciting. It'll be interesting to see how the measures change in those who improve or those who their symptoms worsen. I'm going to use these findings really to support a large independent research grant to continue this line of research. At some point in the near future, I hope to see you be using these measures to better understand manual therapies and exercise for treating cervical radiculopathy.
Yeah, I look forward to that, and I'm sure the rest of the profession does as well. That'll be fantastic. So, Ken, I asked this question of everyone who comes on the podcast, and one of the motivations that I had to make these podcasts public is to help to motivate and assist practitioners and students to pursue research careers in chiropractic science. We've just talked about all of the cool stuff that you've been doing, and the interesting twists and turns that life takes as we go through a career in chiropractic research or research in general. So I'm wondering if you could offer any advice to these aspiring chiropractors or students who may wish to become scientists.
Yeah, this is great. Great, Dean, and it's something I'm really passionate about. I think the most important aspect is finding mentors who can help guide you on your career path. And I would, reach out early, and start building your network, even if you're just maybe partly interested in a research career or research in general. I found that every chiropractic researcher I've reached out to has been very open and happy to offer help and advice. Any of your readers, please reach out to me. Send me an email, and we will find a time to chat. And I'll give you my honest advice and let you know my experiences. I truly enjoy mentoring future scientists and want as many chiropractors as possible to be involved in research and really grow the research base. Next, I think is you need to start getting research experience, especially if you are interested in pursuing a PhD, because you need to be you want to get into a competitive program, and you need the experience to be competitive for the application. So I would start working on a project, no matter how small it is. For example, I started with an educational survey of chiropractic students. But the best way to learn is hands-on. So again, get started. There's been a major push, at least in the field of neuroimaging, for data sharing and open science, which I think will become the norms for all fields. You could start working on a neuroimaging research project if you wanted to. There's an abundance of imaging data sets online for free, ranging from 20 to 30 participants to hundreds to thousands. Most of the software and image analysis tools that we use are open source, so they're free, and there's lots of tutorials online to learn these techniques. And you don't actually need fancy hardware or a supercomputer. Your PC or Mac is enough to get you started. There's openneuro.org and openpain.org. I think these would be just good places to start to get your hands on some data. So that was, get working on a project. At least, start working on your skill set a little bit and get involved in research any way possible. Next, I think it's important to just have an understanding of how research is funded and how it works. What projects are fundable, what training opportunities are available for chiropractors. Your research mentors can definitely help you with this. For the U.S., which I'm most familiar with, the National Institutes of Health is the main health research funding body. There are several training opportunities available for chiropractors, which could cover tuition, salary, healthcare, research expenses for a PhD. The examples here are the F31 and F32 fellowships, and also as a chiropractor, you're considered, a doctorally trained individual, and your DC makes you even qualify for the career development grant that I'm being supported on right now. Another thing, and student debt is also a major barrier for many for receiving research training. A lot of the times the research, you don't necessarily go into it for the salary. You do it more because you're passionate about it. But the NIH knows that, and they want more clinicians to become active researchers. So the NIH has a student loan repayment program, which will help pay off student debt for researchers, and chiropractors qualify for this. So right now, the award is quite substantial. They've just increased it to $50,000 a year of student debt if you can commit 20 hours a week to research. There are some qualifications that you need criteria to meet this the requirements of the award. I'm here to help you with that if you want. I'm currently receiving loan repayment benefits and have recently applied for an additional 2 years of the loan repayment award. All of the NIH funding is competitive, so you kind of have to have a strong application. But I'm an ambassador for the program, so I can help anyone with any questions regarding that application process. So, I guess the main things are find your mentors, get as much research experience, at least get started to show that you have some research experience, and then kind of just have an understanding of how research works, how the funding works, and take advantage of possibly some nice opportunities that exist to help chiropractors get training. So please reach out to me. I'm happy to assist in any way I can.
Well, Ken, thank you so much for going through that, especially the part about finances. I do get quite a few questions about this from chiropractors and students that are interested in getting into the research career. And so I think that's a huge thing. So I'm really glad you've addressed that. I don't recall any other guest actually talking about that. So thank you so much for going through that. And I know you have a lot of knowledge about these repayment programs. So that's totally amazing. And again, thanks so much. And thanks for coming on the podcast. I wanted you on for such a long time. And I remember us talking back at ACC RAC, I think it was in 2017 or something like that. We were talking about getting you on, and we finally did, even with COVID.
Yeah. COVID delayed us a few months, but made it in. So yeah,
no
it's
doubt.
a great opportunity, Dean. I really appreciate it.
Ken, thanks so much again for coming on, and really appreciate it. It was fascinating discussion, and I hope to have you back on sometime. You can tell us about all these other cool studies you've been involved in. Yeah,
that sounds great. Love to discuss maybe two years from now. We can discuss, hopefully we have some interesting results from our current project in cervical radiculopathy patients.
Awesome. Thanks, Ken.
Great, thank you.
Thanks again for listening to this episode with Dr. Ken Weber. I'm looking forward to more interviews, and I hope you are too. Take care. Bye for now.